Good afternoon, everyone. Today I'll be presenting on behalf of Medicine 4, Wailed. Presenting a 56-year-old male, a daily wage laborer, who presented with chief complaints of fever with chills and rigors for the past 4 days, associated with cough with expectoration for the past 4 days, and breathing difficulty for the past 1 day prior to presentation. History of presenting illness was he was apparently well till 4 days back when he developed fever with chills and rigors, cough with mucoid whitish expectoration, and left-sided chest pain. Pleurisy chest pain, with breathing difficulty worsening from MMRC grade 1 to 2 to 3 grades, associated with generalized fatigue, loss of appetite, and nausea. No history of hemoptysis or TB in the past, and there was associated history of delirium associated with only with the fever spikes. For this, he initially took treatment from outside with no significant relief. He was initiated on amoxicillin clavulanic acid from an outside local hospital. Past history, he was a known diabetic for the past 10 years on oral antidiabetics with poor glycemic control. There was no history of any active infection in the family at the time of his current illness, and he did not have any addictions. No history of any loose stools, vomiting, no yellowish purulent expectoration, sore throat, coryza, or headache, neck pain was noted associated with any of these complaints. On examination, he was well-built, tachypnic, with a blood pressure of 100 by 70 millimeters of mercury, heart rate of 90 beats per minute. Saturation was 88% on room air, with a temperature of 105 degrees. His GRBS was noted to be 498 milligrams per deciliter, with the serum ketones of 0.2 millimoles per liter. On general examination, no pallor, icterus, clubbing, koilonychia, pedal edema, or lymphadenopathy. No features of elevated JVP were noted. Systemic examination-wise, his respiratory rate was 32 breaths per minute, abdominothoracic pattern with use of accessory muscles. On examination, he was noted to have increased vocal fremitus in the left interscapular region, with coarse crepitations heard in left interscapular and mammary region, as well as bilateral basal crepitations were also present. CVS, S1 and S2 were heard, no murmurs. Per abdomen, soft, non-tender. Liver was palpable, 4 centimeter below the costal margin. CNS, no focal neurological deficits were noted. Summary, middle-aged male with uncontrolled blood glucose levels working in soil, presenting a syndrome complex of lower respiratory tract infection, more in favor of lobar pneumonia, mostly localized to the left upper and middle zone. So the differential diagnosis that we initially considered acquired pneumonia with possible microbiological etiology of Streptococcus pneumoniae, Staphylococcus aureus, Klebsiella, Haemophilus, or Burkholderia was also kept as a differential in view of his uncontrolled blood sugars and history of working in soil. His investigations revealed the following results. His counts were 1,500 with 85% neutrophils, and toxic changes were also noted. Urea create of 47 and 1.3. He had associated hyponatremia 122. CRP was 161. LFT was grossly normal. HbA1c was noted to be 12.7. ABG pH of 7.43 with PO2 of 49, PCO2 of 31, HCO3 of 20.6, and lactates were noted to be 2.8. On further evaluation for his hyponatremia, he was noted to have decreased serum osmolarity with increased sodium excretion in urine. This was a chest X-ray of this patient. So it showed non-homogeneous opacity of the left side, predominantly in the upper and the middle zone. CT thorax was also done to look, so it showed extensive areas of consolidation with ground glassing opacities, predominantly involving the left upper lobe with mild left pleural effusion. Ultrasound was suggestive of only a grade 1 fatty liver. So in view of consolidation noted predominantly in the left upper lobe, the differentials considered were, looked at were the various causes that can lead to a upper lobe consolidation. So they were classified into multiple categories. It can be either due to inhaled gases, secondary to smoking, centrilobular emphysema or paraseptal emphysema, or impaired mucociliary clearance associated with cystic fibrosis, or in relation with inhaled particles, pneumoconiosis such as silicosis or hypersensitivity pneumonitis or chronic eosinophilic pneumonia. Along with that, granulomatous disorders such as TB, sarcoidosis, Langerhans cell histiocytosis, and metabolic diseases such as hyperparathyroidism, CKD, or metastasis were considered as differentials for the upper lobe consolidation. A few things to be kept in mind in view of an upper lobe consolidation is the lung itself is a very very dynamic organ in terms of lung apex being overventilated and underperfused, which leads to specific disease patterns which are particularly found in the lung apex. So inhalation of toxic substances can cause maximum damage to the lung apices. Similarly, smaller inhaled particles which are not cleared by the mucociliary clearance also get trapped in the small airways, and because of the lack of lymphatic clearance in this place, there are certain infections and hypersensitivity features which are associated, mostly seen in the lung apices. So I would just like to discuss a few of the radiological characteristics that would be associated with these upper lobe consolidation. So one of the first things are centrilobular emphysema. Here, there is permanent abnormal enlargement of the air spaces distal to bronchioles, accompanied by destruction of the alveolar walls without fibrosis, predominantly in the upper lobe and associated mostly with cigarette smoking. So this is the diagram image that we can see here, where we can see multiple dilated air spaces. Similarly, silicosis is a chronic secondary to chronic inhalation of crystalline silica, mostly seen in mining and sandblasting industries. Here we can see small symmetric nodules that calcify and predominantly involve posterior portions of the superior segment as well as the superior portions of the lower lobes. It has a very close appearance with poll workers pneumoconiasis as well. Sarcoidosis is a granulomatous disorder, which is a multi-system disorder, affects multiple organ systems. Predominantly, it involves hilar and mediastinal lymph nodes, but associated with some nodules, which can be also seen, which are usually predominantly seen in the bilateral upper lobes. Other than that, tuberculosis, the characteristic feature of which is cavitation or upper lobe fibrosis. Hypersensitivity pneumonitis is a extrinsic allergic alveolitis, which can be acute or chronic. Usually show small ill-defined centrilobular nodules and bilateral airspace consolidation that have mid and upper zone dilatation. It's known as hypersensitivity pneumonitis. Apart from this, mostly seen in pediatric population, cystic fibrosis due to impaired mobilization of secretion, it commonly affects the upper lobes, and there is increased hyperinflation of both the lungs, secondary to the obstruction of the small airways that is noted, with thickening bronchiectasis and mucus impaction that is noted. Another granulomatous disorder is the Langerhans cells histiocytosis, which is almost exclusively seen in smokers, however, without any sex predilection. It also commonly involves the upper lobes, diffuse symmetric nodular opacities and cysts, which are noted in the upper lobe. However, coming back to our patient's blood culture and sputum culture both grew Burkholderia pseudomyeli. So just few words about melioidosis. Burkholderia pseudomyeli is a gram-negative environmental bacterium, and it is the etiological agent for melioidosis, which is a life-threatening infection, estimated to account for almost 8,000–9,000 deaths per year worldwide. Diabetes is the major risk factor for melioidosis. It is endemic mostly in Southeast Asia. The risk factors mainly are rheumatic heart disease or congestive cardiac failure, COPD, smoking, and diabetes. Acute fulminant sepsis with multifocal lung infiltrates to chronic infection that can mimic tuberculosis are noted. It has a wide range of spectrum. The presenting feature can be pneumonia per se, or it can develop secondary to an initial illness at a distant site as well. The gold standard for diagnosis is culture and isolation of Burkholderia pseudomyeli from the patient samples. Severity and chest radiographic findings associated with primary and secondary pneumonia. Primary pneumonia with blood culture positivity is known to cause septic shock, with upper lobe involvement seen in 45% and lower lobe involvement seen in 60%. Whereas primary pneumonia with blood culture negative has a lesser rate of death as well as septic shock, with upper lobe involvement seen in 50% and lower lobe involvement in 38%. This is statistics that has been taken from the territory of Australia predominantly. The most common manifestation of melioidosis is pneumonia. Other manifestations include skin infections, genitourinary infections. Bacteremia with no evident clinical focus is also noted. Soft tissue abscess, septic arthritis, osteomyelitis are also noted. So learning objectives for this is, what are the differentials that should come into your mind for in relation to an upper lobe consolidation, as well as in our also we need to keep a high index of suspicion for melioidosis to pick it up, because it's not usually that that's not something that we actively look for. Thank you.
Thank you, Dr. Keziah, for this wonderful elaboration on several diseases which affect a particular lobe. Any questions from the audience or anybody else would like to ask questions? Here it
It's very
is.
difficult in talking about a lot of things which are not related to this. I agree it's caused a lot of confusion in your mind, and that was a learning field. When you present a patient, it is better to maybe filter it down to something which everybody can also learn along with it. Otherwise, when you put in so many Excels, so many percentages and numbers, it's very difficult for people to take in and very short.
I was also a little finding it difficult to follow why you had put in all those things. Then definitely one take-home point is, I think, in the setting of a patient with a diabetes, I think even if it is a patient who is coming in de novo from the community, conscious that we need to consider is the possibility of it being a melioid. Especially with this present situation, we are having more and more of these patients. That changes several of our management issues. So if it was only a patient with a community acquired pneumonia, who don't have any risk factors essentially for patients who are like for any drug-resistant infections, the usual risk factors that we look for are what? Any exposure to antibiotics, any exposure to healthcare institution in the last 3 months, or any other interventions that the patient might receive, structural lung diseases. These are the ones that we look at when we decide on empirical antibiotic cover when a patient comes. But this has probably thrown a bit of a spanner into our wheel of trying to decide empirical antibiotic therapy and having to consider this particular bacteria, which might require a different antibiotic. At least capsaicin is something that you need to keep in mind, or at least Septran. Okay, so this is a patient who came in very acutely. There is a large left lower lobe consolidation that is there. One of the other differentials that I would have considered looking at that particular chest X-ray, if it were such a large pneumonia, would be any of the other causes of lobar pneumonia like streptococcal, staphylococcal. And I was also looking for whether the fissure is sort of a bulged to suggest that the patient might have a bulging fissure sign of either seen in Klebsiella or something. It's important that we keep it in mind, but